All right, good afternoon, everyone. Welcome, and thank you for being part of history as we launch the very first session in the ARDS Innovation Knowledge Education Group's webinar series under the Society of Critical Care Medicine. My name is Javier Amador Castañeda, and I am a respiratory care practitioner at Columbia University Irving Medical Center, and proudly serve alongside my colleague, Dr. Bushra Amina, as co-chair of SCCM's ARDS Innovation KEG. Just to go over some disclosures of mine, I am the Chief Executive Officer of the Interprofessional Critical Care Network, and I am also a council member for the European Society of Intensive Care Medicine, serving as their North American representative. Today, however, I'm here strictly as your host and moderator, so these roles pose no conflicts of interest. And just to give you guys a quick word about SCCM, if you're passionate about advancing critical care practice, SCCM offers a vast network, cutting-edge education, and professional development opportunities. You'll find more details in a membership form inside our resources under Documents tab. We hope that you'll consider joining this amazing community. And just to go over some housekeeping rules, once again, under resources at the bottom of your Zoom window, you can open it at any time and download the speaker's supporting articles, access the speaker's ResearchGate profile, which has over 300 publications, and view SCCM membership information. In addition to that, at the bottom, you have a Q&A and a chat. For the Q&A, please post any lecture-related questions here. And for the chat window, use it for general comments or any technical issues that you may have. If you see a great question, please upvote it so that it rises to the top, and we'll prioritize those during the live Q&A. Dr. Mina and I will be monitoring the chat. And lastly, within 24 hours, you'll receive a brief survey, and your insights guide future KEG events. So please take a minute to respond. At this point, I'd like to invite my fellow co-chair, Dr. Bushra Amina, to say a few words and introduce himself. Dr. Mina?
Yeah, hi. Thanks for joining us. I'm Bushra Amina, Chief of Pulmonary Critical Care at Northern Worcester Hospital, and also Chairman of Medicine. I'm involved in multiple levels at the site of critical care, and we're happy to initiate this educational sessions about ARDS, which is part of the KEG ARDS, which is part of the activities of Society of Critical Care Medicine. Without any delay, we'd like have Professor Gary Nieman be introduced to hear from him about controversies in ARDS.
Thank you. Dr. Mina, do you have any disclosures?
Disclosure, I'm a medical consultant for Inari, has no conflict of interest for the ARDS.
Thank you so much, Dr. Mina. Now, it is my honor to introduce today's presenter, Professor Gary Nieman. Professor Gary Nieman is a senior research scientist in the Department of Surgery at Upstate Medical University in Syracuse, New York, where he also directs the Translational Critical Care Laboratory. Over a career spanning more than 3 decades, he has become one of the world's foremost investigators into the pathogenesis of ARDS, ventilator-induced lung injury, and multiple organ dysfunction syndrome. A prolific scholar, Professor Nieman has authored over 140 peer-reviewed publications, contributed numerous book chapters, and is the holder of 5 U.S. patents, including the landmark patent Method of Preventing Acute Lung Injury. His laboratory was the first to use real-time in vivo microscopy to visualize soft pleural alveoli during mechanical ventilation, an innovation that fundamentally changed our understanding of dynamic alveolar mechanics and paved the way for safer ventilation strategies. Building on those discoveries, he co-developed the time-control adaptive ventilation, TCAV method, for setting APRV, an approach designed not merely to limit ventilator-induced lung injury, but to prevent ARDS before it becomes established. This work has been supported by a current NIH RO grant with Dr. Jason Bates at the University of Vermont and Dr. Don Gaver at Tulane, aimed at defining the biophysical mechanisms of ventilator-induced lung injury, and also a Department of Defense grant with Dr. David Kaska at the University of Iowa, integrating TCAV into military transport ventilators. Professor Nieman's collaborative spirit extends to clinical translation. He partners with Dr. Nader Habashi at Adams College Shock Trauma Center, and Dr. Luis Gatto from SUNY Portland on multi-center efforts to deploy TCAF as a preemptive therapy in trauma, sepsis, and donor lung optimization. His contributions have earned multiple awards, invitations to keynote at international symposiums, and editorial roles for leading pulmonary journals. With that background, we're privileged to have him guide us through today's session, a paradigm shift in protective mechanical ventilation for ARDS. Stabilize first and then gradually recruit. Professor Nieman, the virtual floor is yours.
Thank you very much for that nice introduction. I will share my screen. Well, good afternoon, and I would like to very much thank the Society of Critical Care Medicine and ICCN for inviting me here today to discuss some of the work from my laboratory at Upstate Medical University and now also at Cornell University. And as you can see from the photo, my laboratory looks much more like your ICU than it does the standard molecular laboratory. And what we have developed is actually a translational lab, in that the animal models are very closely designed to follow the pathophysiology of a patient in the ICU. And therefore, anything that we find in these animal experiments can be rapidly translated into bedside treatments. Today's title is a paradigm shift in protective mechanical ventilation, a stabilize and gradually recruit approach. And what we're contradicting is the current standard open lung strategy in which we first recruit with some type of recruitment maneuver, and then gradually and then an attempt to stabilize after the recruitment. And I'm going to show you some evidence that I think if we reverse that strategy and actually stabilize the lung and then gradually open it over time, I think it's we can improve outcomes. So first, I guess the question is, do we even need new protective ventilation strategies, or are what we are working with, are they working just fine? And you're all very familiar with the ARDSnet or the publication in New England Journal of Medicine showing that lower tidal volumes were superior to higher tidal volumes in ARDS-related mortality. So this paper was published in the year 2000, and it demonstrated a significant reduction in mortality just by lowering the tidal volume. So essentially 2000 established the gold standard of ARDS mortality at 31%, and hopefully we're going to improve on that over the decades. I'm just going to show you a couple references here to suggest that we really haven't further reduced mortality since that 2000 paper. And this is in a publication by Dr. Bellini, and looking at the mortality in intensive care units in over 50 countries secondary to ARDS. They found that mortality was at 35, 40, and 46% for mild, moderate, and severe ARDS. Again, significantly higher than the 31% of the ARDSnet study in 2000. Also, for the open lung approach, in this recent study, using low tidal volume and rapid recruitment maneuvers, they found that actually the open lung approach increased 28-day all-cause mortality. So what is the current hypothesis for this low tidal volume ventilation strategy? Well, we have ARDS causes a heterogeneous lung injury. We all know that. We have a small volume of normal tissue, usually in the non-dependent lung regions, affectionately known as the baby lung, and a large amount of collapsed and unstable and edema-filled lung in the dependent regions. So the strategy was really sort of featured by Dr. Gattinoni, and he termed this pathophysiology concept as the baby lung, in that there was a small amount of normal tissue but very reduced in volume. And as you can see with that yellow line, there's a very clear-cut demarcation between the collapsed and edematous dependent portion of the lung and the open non-dependent portion. And so the strategy was for low tidal volume was designed to protect and rest. So we're going to protect the baby lung by giving small tidal volumes, 6 cc's per kilo or less, and low plateau pressures of less than 30 centimeters of water. And we're just going to let the collapsed tissue rest by leaving it totally out of the ventilatory cycle until the lung heals. So why didn't this work? This sounds like a very logical way to approach ventilating the ARDS patient. Well, what if the two-part compartment model and of the baby lung is not actually the pathophysiology that drives ventilator-induced lung injury? If this is the case, then the ARDSnet low tidal volume protocol would actually be designed for the wrong disease. So to recap again, here we have the normal lung. In ARDS, a great deal of the lung is either collapsed or edema filled. If we try to push a normal tidal volume into that lung, we're going to overdistend and essentially pop the normal lung like you would a balloon that's overinflated. I want to show you evidence suggesting that overdistension of truly normal tissue is not the primary mechanism of VILI. This was a study by Dr. Gatnoni's group. Dr. Prodi is the first author, in which they ventilated pigs, normal pigs, so essentially the whole lung is the baby lung, at very high distending pressures and volumes. And so they had 4 different groups, and in all groups, they used a very high strain of 2.5, exposing these lungs to overdistension by high pressures and volumes. And then he separated the groups by how much dynamic strain they had. So all animals, all groups had very high static strain, very high volumes and pressures. And in one group, they had a high dynamic strain in which they had little PEEP. And so the lung would collapse and open with each breath. And in the other, they had very low dynamic strain. There wasn't a great deal of volume change because there was a 75% of the strain was due to PEEP. And then they assessed lung damage by the accumulation of pulmonary edema. So in the animals that had high dynamic strain, there was 5 for 5. All 5 animals developed pulmonary edema. When there was lower dynamic strain, only 3, even lower 2. And when there was very low dynamic strain, the edema actually was reduced. So this study clearly shows that you can subject a normal lung with very high volumes and pressures and not cause injury as long as you maintain a static strain and minimize the dynamicness of the strain. So just high pressure and volume alone will not damage normal lung tissue. Also, there's problems with long-term atelectasis. Atelectasis that's going to persist for days or even weeks can be a problem because this progressive atelectasis will add more strain during ventilation to the remaining normal lung, and the lung will sort of fall into a VILI vortex as described by Marini and Gatnoni. If atelectasis is long enough, the lung tissue can become fibrotic. The decreased diffusion area will increase FiO2 requirements. Collapsed lung is associated with loss of surfactant function, and you need lung stretch to release surfactant function and stimulate further molecular release. The hypoxia, hypercapnia, and the stretch receptors in the collapsed tissue all make the patient ventilator dysynchrony, which is a big problem. The collapsed lung will increase the pulmonary vascular resistance and leading to right heart failure. Low tidal volumes, or tidal volume acts as a pump, and low tidal volumes will decrease the pump, which will reduce lymph flow and exacerbate edema formation. And of course, eventually we have to reinflate the lung. So the low tidal volume and open lung approach used over the last 24 years uses basically 4 parameters. We use a low tidal volume, a low plateau pressure, PEEP set by EIT or compliance or blood gases, and some type of a rapid recruitment maneuver over seconds or minutes. And over over 2 decades, we've tried every combination of these 4 parameters and still haven't significantly reduced ARDS-related mortality from the 2000 ARDSnet study. So we started out with ARDS mortality in 2000 with the ARMA study, and we were very excited that we had really accomplished a major goal. However, 24 years later, we find that we still have a significant problem with ARDS, and so more studies necessary. And we would have hoped that within this time period, we would have mortality rates of less than 31%. And insanity is defined as doing the same thing over and over again and expecting different results. So if not low tidal volume, then what? I think what I'd like you to remember is one key pathophysiology of the lung that is caused by ARDS is that it makes the lung become time and pressure dependent. So what does this actually mean? It means it's going to take more time for alveoli to open and less time for them to collapse at any given airway pressure. And if this is the case, and this is amplified by ARDS, it would suggest that an extended time at inspiration would be needed to open alveoli, whereas a very brief expiratory time would help prevent alveolar collapse. So based on this physiologic knowledge, what tools do we have in order to stabilize and open the lung? So let's have a look at our mechanical breath profile toolbox and see what we have. So we look at the entire mechanical breath, and we call it the mechanical breath profile, which consists of all airway pressures, volumes, flows, rates, and just as importantly, the time that they're applied during inspiration and expiration. So in our ventilator toolbox, we have, of course, plateau pressure, PEEPs, IE ratios, inspiratory and expiratory flows, respiratory rates, and tidal volume. So we can manipulate all of these in an attempt to improve our ventilation strategy and reduce a secondary VILI to our patients. So I showed you this slide before this. We've been looking at these 4 parameters for 2 decades. What's missing? Is there a component of the mechanical breath profile that we should be looking at? And what our group and others believes we should be looking at is inspiratory and expiratory time. So for example, let's take a patient who's on a ventilator, has ARDS, and let's look at tool set 1, which is a volume-controlled conventional ventilation. And we can see we have a fairly short inspiratory duration, a quite long expiratory duration. We set the positive end expiratory pressure, PEEP, and we have a mean and a peak airway pressure. So let's look at our second tool set, this one with airway pressure release ventilation, and we can see a different profile. We have a very long inspiratory phase, termed the CPAP phase, and a very short expiratory phase, termed the release phase. We have a measured peak airway pressure and mean airway pressure. And we also have a time-controlled PEEP, or TC PEEP. And it's time-controlled because the release phase is so short, the lung doesn't have time to depressurize, maintaining a positive pressure when the lung is reinflated. So it isn't set behind the ventilator, but it does remain a fact. So now if we compare the 2 tool sets, we find that the peak airway pressure is similar. The mean airway pressure is slightly higher in APRV because the longer CPAP phase. And the set PEEP and the TC PEEP are about the same. So what's the big difference between these 2 tool sets? It's inspiratory time and expiratory time. They've really been flip-flopped. We now have a very long inspiratory time and a very short expiratory time. And that's really sort of the major difference between these 2 ventilator tool sets. The exact way to set APRV, we have come up with and named it the time-controlled adaptive or TCAV method to set and adjust the APRV mode. And the reason we actually came up with a term for the method is because we found in the literature and from talking to colleagues that there's many ways to set APRV, and we studied sort of a standardized method to at least get a baseline on how this particular method used to set and adjust APRV does work. So what we're really saying is that it's not the wand, it's the wizard. And what do we mean by that? Well, it's not the ventilator mode, it's the method used to set and adjust the mode that's important to lung patient protective care. For example, our mode, which is, say, in this case is the VC mode, that's our wand. The wizard is the clinician. Are you guys listening? The ones who turn the dials on the ventilator. So wizard 1 uses method with a low tidal volume and has a very good low mortality, 31%. Wizard 2 uses a second method with a higher tidal volume, and his or her mortality is higher. Now, we don't say that the VCV mode is bad because of the one method. What we say is method 1 is superior to method 2. And all I'm saying is that this is the same with APRV, that one method of setting APRV could be superior to a second method. And indeed, we recently did a meta-analysis, and in the 20 studies that were in the meta-analysis, we looked at how they set the expiratory time and the release phase, or the T-low. And which I'll show you is one of the most important aspects of properly set APRV. And we found that 65% of the T-lows in these studies were set arbitrarily. T-low had a range between 50 and 75% of the peak expiratory flow in 30%. And in only 5%, or one study, did they actually use the TCAB method for setting T-low. This just goes to show that there's a wide variety of the way to set APRV out there in the literature. And there we go. So what we have here, this is the lungs at the end of an experiment. And this is set with a TCAB method, and it was at 0.65 seconds. And this was not set at TCAB, both are APRV at 1.3 seconds. And you can see the big difference in the amount of collapse and reopening with just a slight increase in expiratory time. So both APRV modes, but set differently, have a very different outcome. And in this study by Dr. Jain from my laboratory, he found on average the difference was only 0.6 seconds, and yet it led to a significant increase in tissue injury using this extended T-low. And this was from that experiment from Dr. Jain. And we have both normal tissue and acutely lung injured tissue in this study. We have a unique method model where we actually just injure part of the lung, so we can look at what the impact of our ventilation strategy on both ARDS tissue and baby lung tissue. And in all cases, in both of these groups, the lung was overdistended, and we ventilated these animals with a peak airway pressure of 40 centimeters of water for 6 hours. So all tissues were overextended by definition, by current definition. We then had a group with a long T-low of around a second, and then the very short T-low of about a half a second. So there's between about, again, on average, a 0.6 second difference in the T-low is the only difference in these studies. And we can see in the normal tissue that was overdistended with a long T-low, there was a significant amount of histologic damage, as there was in the acutely injured tissue. However, just by shortening the T-low and setting it to the TCAB method, we protected the lung tissue in the baby lung, and we protected the lung tissue in the ARDS lung. So again, this study just shows the critical importance of setting the T-low correctly. So I'm going to sort of show you the does it work first, and then show you how it works second. And start with some animal data from my laboratory. And we have an in vivo microscope where we can actually look at subpleural alveoli in real time and see how a mechanical breath impacts these subpleural alveoli in both normal and acute lung injury. So here we have the dark field metallurgy microscope, and it's looking at a rat lung. You can see the light on the pleural surface of the lung. We ventilate using critical care grade ventilators, And we captured these alveolar mechanics, the change in size and shape of alveoli in a breath-to-breath fashion on a computer, and analyzed it with computer image analysis at a later time. And we measured the animal's hemodynamics. So this is a study in which we captured film at both inspiration and expiration. And in the black and white photos, you can see those little black circles. Those are actually subpleural alveoli. And then we color-coded them with the computer image analysis yellow to analyze the number of alveoli open at inspiration and the number at expiration to find out if they're recruiting and de-recruiting. And we studied 4 different groups. We studied low tidal volume with a PEEP of 5, APRV with a long T-low, low tidal volume with a PEEP of 16, and APRV with a short T-low set with the TCAP method. And then we looked at the the percent of the photomicrograph that was covered with alveoli at both inspiration and expiration. So at 5 centimeters of PEEP, you can see that there was a few alveoli open, only over 20% of the field, and that there was a big separation between inspiration and expiration, meaning that there's also a lot of recruitment, de-recruitment. So low tidal volume, 5 of PEEP, few alveoli recruited, and there was a great deal of recruitment, de-recruitment with each breath. If we increase the PEEP to 16, we stabilized the alveoli. There was very little recruitment, de-recruitment, but there was still a lot of alveolar collapse. We went to APRV with a long T-low, and because of the extended time at inspiration, we opened the alveoli, but because of that long T-low, they collapsed at expiration, and we had a lot of recruitment, de-recruitment in this group. The group that worked, that was most effective, was the APRV with a short T-low set with the TCAB method. This ventilation method recruited alveoli and also stabilized them. Next, I'm going to show you a study from our physiology lab. And again, it's a translational laboratory. And the injury that we use is a sepsis and gut ischemia reperfusion injury model that causes a secondary ARDS and multiple organ dysfunction. And in this study I'm going to show you, we had 4 different groups, APRV set with the TCAB method, low tidal volume set with the ARDSnet method, and a sham that we didn't injure. And again, the injury was sepsis and gut ischemia reperfusion. The x-axis is time at 48 hours, and the y-axis is the PF ratio. And what we found is that in the low tidal volume group, they reached the criteria for acute lung injury of a PF ratio of less than 300 at 21 hours. The criteria for ARDS of a PF ratio less than 200 at 36 hours. However, at 48 hours, our APRV group set with the TCAB method still had the same PF ratio as the sham uninjured animals. Looking at static compliance in the same 4 groups, we found that the static compliance in the APRV group was actually higher than it was at baseline. It did not fall in the sham group and was significantly reduced in the low tidal volume group. And as you all probably have seen this paper by Dr. Marcelo Amato in 2017, where they found that there was a better indice of morbidity and mortality for ARDS with mechanical ventilation than just a low tidal volume. It was driving pressure delta P, and driving pressure is equal, can be calculated by tidal volume divided by respiratory system compliance. And so obviously we try to keep driving pressure low by decreasing tidal volume, but you can also reduce driving pressure by increasing the respiratory system compliance. And I want to show you that. I wanted to show you that because this is really sort of the take-home message from these experiments that we were doing. Here we have, this is the animal's lungs at necropsy 48 hours after the beginning of the study in the TCAB method and the ARDSnet method. In A and C, in the whole lung preps, they're both inflated to 25 centimeters of water. So both inflated at the same pressure when the pictures were taken. As you can see in the ARDSnet method, there was a great deal, there was a heterogeneous injury with normal tissue collapse and edema-filled tissue and very inflamed tissue. On the cut surface, we saw interlobular edema and airway edema, which of course was not seen at all. It was a very non-edematous lung in the TCAV method. So we have a tidal volume. We measure tidal volume with the TCAV method. We don't set it. The lung determines its own tidal volume. And the measured driving pressure was 9 centimeters of water. Obviously, the tidal volume was 6 cc's in this group by definition, but the driving pressure was 27. So how do you get a higher driving pressure with a lower tidal volume? It's because our compliance was so much better. And as we just showed, you can decrease the driving pressure by increasing compliance or decreasing the tidal volume. Also, for you clinicians, we do not control the source of inflammation, the source of infection. Excuse me. And these animals were as high as 60 liters positive fluid, and we still kept the lungs dry with APRV. We did a systemic review comparing patients at Maryland shock trauma being in the surgical intensive care unit or SICU with 15 other SICUs using standard of care mechanical ventilation. The bar and whiskers are the 16 other ICUs, and the little black dot is the Maryland shock trauma value. So first we looked at the injury score, severity injury score, the ISS, and we found that the Maryland shock trauma patients were in the upper quartile. So these patients are not less sick than the group we're comparing them to. For percent of patients that developed ARDS, we're way down at the bottom whisker for shock trauma, and there was a 14% ARDS incidence versus 1.3 at shock trauma. Percent mortality, again, way down at the minimal, 14.1 to 3.6, and none of the patients at shock trauma died of respiratory failure. Another way to assess the ventilation efficacy is to look at the lung injury prediction score, or LIPS, and the higher the LIPS score, the larger the percentage chance that your patient's going to develop ARDS. In the study that I just showed you, the LIPS score was 8.7, and therefore we should have had an incidence of ARDS of 35%, but instead we had an incidence of 1.3% on TCAV. So again, looking like the TCAV is highly effective in patients. This is one case study published by a pulmonary fellow in my laboratory. And there was a patient who was on ECMO and PCAC for 21 days. You can see very bad whited out X-ray, very poor blood gases. We move on to 30 days on ECMO, 36 days on PCAC. Blood gases have gotten worse, still a whited out chest X-ray. The pulmonary fellow transitioned this patient to TCAV, and in 2 days had significant lung opening, improvement in blood gases. In 11 days, the lung was fully recruited, gases were normal, and the patient was decannulated, extubated, and released. So this was a great success by a student in the laboratory that had practiced our techniques in our animal models. We have an adult clinical, we analyzed APRV adult clinical meta-analyses for a a consensus conference guidelines meeting that we just had. This data isn't published yet, but I just wanted to present it to you. There was 13 parameters were tested in 8 published meta-analysis on adult APRV patients. It's qualitative. We just had a negative, positive, or a neutral effect. APRV had a negative impact on none of the 13 parameters tested. It had a neutral or positive effect on pneumothorax, oxygenation, ventilator-free days, ICU length of stay, and all-cause mortality. And it had a positive impact on peak airway pressure, mean airway pressure, compliance, in-hospital mortality, and 28-day mortality. So again, looking at the current literature, APRV appears to be highly lung protective. So now that we've seen that the data suggesting that APRV set with the TCAB method or APRV really set in any way that has been published to date does work, let's find out how it works. And really to drill down to find out how VILI works, we really have to look into the microenvironment and see how the ventilator impacts the alveoli and the alveolar ducts. As we know and shown already, that ARDS causes a heterogeneous ventilation, regional instability and collapse. And this collapsing, expanding with each breath is defined as static trauma, and stress multipliers, which are regional areas of collapse, tend to cause overdistension in the tissue that's surrounding them. So static trauma and volume trauma are still the two mechanisms that drive alveoli, drive ventilator-induced lung injury, but we have found that the volume trauma occurs regionally around these collapsed tissue, not in purely normal tissue. So in order to study these dynamic alveolar mechanics, we came up with a method of in vivo microscopy, as I've already demonstrated to you, and I now wanted to use that tool and show you ventilator-induced lung injury at the alveolar level. So again, we're going to start with what's normal lung look like. So normal lung has a very homogeneous, stable alveoli population. This is a rat lung, a normal rat lung. Each of these individual circles is an alveolus, and you can see they move very little during standard tidal ventilation in the 2 dimensions we can see with our microscope. It's about a 2% change with each breath. So all uniformly inflated and all very stable. That's what the normal lung looks like, and that's what we try to achieve with our ventilator in an acutely injured lung. We modeled this using hexagons because alveoli share walls. And so in order to identify the impact of ventilation, of abnormal mechanical ventilation, we have to use the shared alveolar wall concept. If you see alveoli depicted as individual grapes, that's not how alveoli function. And we really need this hexagon where all the walls are interconnected. So let's first look at static trauma. This is a rat lung with ARDS. You can see this is the apical lobe, and you can see here the edge of the apical lobe. This is the diaphragmatic lobe, and you can see the incredible instability with each breath. So what you're looking at is static trauma at the alveolar level as these alveoli pop open and collapse shut. So we model this again with our hexagon model, and here we see that the alveoli are collapsed here. This is the alveoli open, nice thin alveolar walls, and collapsed histologically. The alveolar walls fold in like a paper bag, and the walls look thick because all of the walls have crumpled down upon each other. So we have the part of the alveoli that are opening and closing, and they're going to be injured much like you would injure how a paper clip would be damaged. If you bend a paper clip back and forth a dozen times, it's going to break. Same thing with an alveolar wall. Here we have the open lung with the nice thin walls and then collapsed and wrinkled like a paper bag. And I also want you to notice that the alveoli that are connected to the collapsing alveoli. These alveoli here are overdistended because they are connected here and they are pulled in as this tissue collects. So that's why it's important to understand from an alveolar perspective that these alveoli are interconnected. So here we have it modeled. So you can see with each collapse, of course, these alveoli are going to be like the paper clip being bent back and forth, and these alveoli are being overdistended with each breath. So static trauma is really a double-edged sword. It's going to injure the alveoli that are collapsing and also the alveoli that are adjacent with connected walls. So now let's look at volume trauma and the concept of stress multipliers. I think the best example of what a stress multiplier is we had this round board, and these lines going through it are the lines of force. And in this board, we have no stress multipliers. And then we put a defect, which we're going to call a stress multiplier, in each of these boards. And we're going to pull in each direction and see how much force it takes to break the board. So you can see that around these stress multipliers or defects, you can see how the lines of force are concentrated, and there's no question where this board's going to break when you pull on it, and it's going to break at much less force than it's going to take for the first board. And so that's a concept of stress multipliers in the lung. And of course, we see the same thing in the lung. In the normal lung on the left, the forces of stress are equally divided. However, if we have regional defects of atelectasis or edema-filled tissue, it's going to concentrate the stress in those areas, and that's where the tissue is going to be damaged. If we take some histologic tissue from an ARDS lung, and then superimpose lines of force through them, you can see how they're concentrated where the alveoli have collapsed. And modeling this, here we have, again, some ARDS tissue. And if we put the lines of force in them, we can see how the forces get concentrated if you have these atelectatic areas. Modeling it, again, we see that with each breath, we get overdistension of the tissue surrounding the defect. So here we have collapsed or edema-filled alveoli. With each breath, you're going to overdistend and damage the alveoli surrounding it. So this is where the volume trauma is occurring. And we found that this spreads very rapidly. So in A, we have a lung tissue using our hexagons with no stress multipliers. We put a stress multiplier in, and we can see that there's about 3 deep of alveoli that are affected and are going to be injured. However, as this stress multiplier grows, you can see how many more alveoli are negatively affected. So what we say is that there's going to be a rapid progression of acute lung injury in a poorer get poorer fashion. So what we want to do is physiologically direct our TLO, our expiratory time or release phase, based on lung compliance, so that the changes in lung compliance actually direct the TLO to get us the proper setting. So how do we do this? So this is the way we personalize the expiratory time using the TCAV method based on the slope of the expiratory flow curve, or PEF. So in this case, our PEF, peak expiratory flow, is 60 liters per minute. We're then going to use the equation PEF 60 times 75% is going to give us a 45 liter per minute termination of expiratory flow. So we want to terminate our expiratory flow at 45 liters per minute. So we're going to turn the dial on the TLO to stop the breath at 45 liters. Now let's see what happens. Here in the normal lung, okay, we have a peak expiratory flow of 60. As soon as it hits a 45, that's when we stop it and reinflate the lung. And it takes, in this case, 0.6 seconds. Now we have an ARDS lung. It has a much steeper slope because we have a low compliance and a very high lung recoil. And we still stop it and reinflate it at 45 degrees, the exact same formula. But because of that change in slope due to the high recoil of the lung and that fast expiratory time is now only 0.3 seconds. So that's how we can use the same equation based on and utilize the peak expiratory flow to get different TLOs for different lung physiologies. So in the normal lung, you're going to have a relatively large tidal volume, maybe 8 to 12 cc's, because more air is leaving and going into the lung with each breath. In ARDS, we often get tidal volumes smaller than 6 cc's per kilo using the TCAV method. This keeps driving pressure low, and TCAV will stabilize the fastest collapsing alveoli with the fastest collapse time constants, because as the lung collapses faster, the TLO, or the release phase, will get shorter. Another way to look at this is we have a healthy patient here with end expiratory lung volume normal, and this very low lung recoil indicated by this very thin spring. So during exhalation, the exhalation flow is very gradual because of the low recoil. Therefore, the slope is shallow. It takes maybe a half second, and there's a relatively large volume of gas and pressure that leave the lung, and therefore the tidal volume is going to be higher and the TC peep is going to be lower. Contrast this to the ARDS patient who has a very high lung recoil and a very low compliance, low EELV. Expiratory flow is very rapid. Therefore, the slope of the expiratory flow curve is going to be very steep. Therefore, the expiratory time is going to be very short, 0.35 seconds. That's going to reduce the tidal volume, and it's going to increase the time-controlled PEEP. So again, just by changes in lung compliance, we also control the amount of PEEP and the amount of tidal volume, and it's done based strictly on the pathophysiology of the patient's lung. This is what you would see on the ventilator. You would look for the peak expiratory flow here, which is around 75. You would then use your peak expiratory flow times 75 is equal to termination. So here's your termination point. You would then turn the dial on your T low in order to terminate that flow at the calculated TEF. And again, remember, it takes, 0.6 seconds difference means a lot. So this was the TCAB method, very little change in volume with the breath, and just a slightly longer expiratory time and a great deal of collapse. So getting the T low precisely correct is absolutely critical in using the APRV mode. So why is time so important? It's because the lung collapses and opens and collapses as a viscoelastic system. So what exactly does this mean? There's a time lag from the time you apply the breath until the lung fully opens, and a time lag from when you exhale and the lung fully empties. So engineers teach viscoelasticity by using a spring and dash pot. So we can see there's a spring attached to a dash in a pot, and the spring moves very rapidly, and then there's a slow, gradual movement up and down of the dash in the pot as a slow strainer slows change in the size or volume. So how does this relate to APRV? So let's first, again, as the title of the talk states, we're going to first stabilize the lung. So we're going to stabilize it with a properly set T low. So here we have a T low, and we're going to release it and for a very short period of time. So this is your T low over here on the pressure time curve. And if we release the T low and short enough, what we're going to do is prevent that dash in the pot from moving. And so the only volume change we get is from the initial phase of the viscoelastic collapse. So if we stop our exhalation very early in the expiratory time, a very short release phase, we're going to prevent alveolar collapse. And here we have an example of this. You can see we have a very long expiratory time here and a very short expiratory time here. With a long expiratory time, notice the unstable alveoli. With a short expiratory time, alveoli do not collapse with each breath. So here, all we've done is decrease expiratory time in order to stabilize these alveoli. So now that we have the alveoli stabilized, let's gradually reopen them. And again, looking at the spring and dash pot, this is the T high or the CPAP phase. So as we hold that inspiratory time, we get a gradual recruitment without an additional cost in driving pressure or mechanical power. So we're just holding the pressure, and as we hold the pressure, the viscoelastic tissue continues to recruit. So if we hold that inspiratory pressure for long enough, we're going to recruit tissue without any additional input in energy. Here we have two rat lungs that have ARDS. The atelectasis is the dark red, and the pink is the inflated tissue. Again, heterogeneous injury. In this lung, we're going to give a 1 second inspiratory hold, typical of conventional ventilation. In this, we're going to have a 5 second hold, typical of the TCAB breath. You'll notice alveolar recruitment when tissue goes from red to pink. So with 1 second, we see no recruitment in that 1 second. And again, remember, both lungs are exposed to the exact same pressure. So it's the exact same pressure, but holding it for 4 seconds longer, you can see the amount of tissue that's recruited without any additional power, energy, or driving pressure costs. So all we're doing here is extending inspiratory time to get all of this alveolar opening. We see the same thing microscopically. Here we hold the breath for 1 second, and here we hold it for 5 seconds, and we see that we get significant amount of alveolar recruitment at this exact same airway pressure, but at different, but with a different inspiratory times. So the take-home messages from the lecture. Remember, the lung becomes time and pressure dependent. So at any given pressure, the lung will take more time to inflate and less time to collapse in the ARDS state. So therefore, a very brief expiratory time will prevent alveolar collapse, and an extended inspiratory time will help recruit these alveoli. This is a typical scenario going from conventional ventilation with severe ARDS to the time when the patient's ready to be weaned. So here we have a patient on ARDSnet low tidal volume on day 0. You can see the plateau pressures are peaked out at 30, and we have a high PEEP of 18. The tidal volume, of course, is 6 cc's per kilo, and the driving pressure is high, even with a low tidal volume, because the compliance is so low. We convert day 1 to TCAV. You can see that the lungs have already started to recruit. There's more lung open tissue. We have a very long inspiratory time, very short expiratory time, because the lung still has low compliance. This yields a tidal volume actually less than 6 cc's per kilo and a very short expiratory time of 0.35 seconds. Driving pressure has fallen because we've actually reduced tidal volume and increased respiratory system compliance. On day 2, we have the lung mostly open now. We only need 1 release phase to help CO2 release. The patient is doing most of the minute ventilation with their respiratory muscles, as can be seen by these gold curves. The release phase, the tidal volume now is over 8 ml per kilo. The expiratory time is 0.5 seconds. The driving pressure is in the very safe range because compliance is almost normal. At day 3, the patient's ready to be weaned. We need no more releases. The entire minute ventilation is being done by the patient. The patient's brain likes a 6.8 milliliter per kilo tidal volume, and the driving pressure is fully normal. So this is a typical turnaround of a patient with the TCAV breath. And again, the compliance is normalized. So effectively what we're doing is we're stabilizing the lung similar to the way you stabilize a broken arm. So if you have a broken arm, you put a cast on the outside of the arm until the bone heals. With APRV, what we do is we cast the lung internally using a precise combination of pressure and time, and we let the lung heal gradually over time, but we let it heal in its normal physiologic open state. Also, what we do is we pull the lung out of this VILI vortex. As Dr. Brini-Gattinoni said, that over time, as the lung progressively collapses, we get more and more tissue dropping out, increasing the stress load on the remaining normal tissue, and ultimately this is going to lead to the demise of the patient. So what's occurring is that low tidal volume and low pressure is pushing the lung into this VILI vortex, and if we don't pull it out, you're going to end up on ECMO. So what we believe the strategy is, using APRV and the TCAV method, we stabilize the lung first with properly set T-low. That pulls the lung out of the VILI vortex, and it no longer is unstable, and it no longer progressively collapses. And then we can gradually, over hours or days if necessary, recruit the rest of that lung and then let it heal in its normal state. And as you recall, this ECMO patient that was on ECMO for 30 days, a very, very sick lung, it took 2 full days for TCAV to get that lung open. So in a less severe lung injury, they may open in 12 to 24 hours. But in this case, it took quite a while to get that lung open. So TCAV is essentially a closed loop control system. So our input, we want an open and stable lung. Our controller is our equation, PEF times 75% equals termination. The effector is the expiratory duration of the T-low. If the T-low is shorter than the collapse time constants of the alveoli, then the alveoli won't collapse, it'll be stable. The output is changes in respiratory system compliance, which drive the sensor, which is the slope of the expiratory flow curve, which is a measure of lung compliance. And this closed loop system will maintain a TLO set necessary to prevent collapse in really any severity of ARDS. Less like can the TCAV method reduce VILI? Surely in my laboratory, we have seen that the TCAV method is much superior to other methods of lung protective mechanical ventilation. And I think there's a substantial amount of clinical evidence suggesting that does work well in patients also. This is the phenomenal team I've had the pleasure of working with, going from left to right. Sarah Sadlin, one of my technicians, Dr. Nader Habashi, myself, Josh Sadlin, my lab manager, and Penny Andrews, Dr. Habashi's colleague. And then the Cornell team, we added Dr. Joaquin Arios, who is a veterinarian anesthesiologist. And I would like to report that we have demonstrated and submitted a paper to Journal of Anesthesiology in veterinary medicine that the method works very nice ventilating horses in the supine position for abdominal surgery. Dr. Abashi and I have published this book, which has all of the physiology and the videos that I just showed you and why they work on TCAV. And I also have a chapter on percussive ventilation, which I also think is a very novel and lung protective way to ventilate patients. So with that, I would like to end the session and thank all of you for listening. And if there's any questions, I will try to answer them. Thank you. And I will stop sharing my screen.
Thank you so much, Professor Nieman, for such an outstanding and great lecture. In the interest of time, I do have a couple of questions, so I'll go ahead and get started with them. We have a question from Carla Luciana Batista. Considering the high inspiratory time, did you observe any risk of barotrauma?
To date, we have not found the pneumothorax have not been significantly increased in any of the meta-analysis that we have analyzed. Again, I'm not a clinician. I've never seen barotrauma in my animal models with the extended inspiratory time. And I don't think they're a problem clinically, but again, I can't speak for the clinician since I'm a basic scientist, but at least in the published clinical literature, it does not seem to be a major issue.
I have another question for Dr. Benjamin Pequena. How should we manage strong inspiratory efforts during high pressure phase, given the necessarily significant variation in transpulmonary pressure? What type of patient should be prioritized for future clinical studies?
Again, I'm not being a clinician. I'm going to try to paraphrase what my colleague, Dr. Nader Habashi, has told patients. That he said, if you transition a patient with very severe ARDS to TCAV, there will be dysynchrony, and in that case, you will need to paralyze until which time that TCAV has recruited enough lung volume to decrease the synchrony. So once the stimulus, once the low PO2 and the high CO2 and the stress receptors no longer are stimulating the brain to ventilate, then you can eliminate the paralytics. But he does say that until that time, there will be dysynchrony, and you will have to paralyze. As for the type of patient, it's again, it's varied from patients at high risk of developing ARDS in shock trauma, because Dr. Bashi's he uses TCAV as his primary mode of ventilation, and in a SICU, as his patients come up from the OR, that are already ventilated or already intubated, and so he puts them immediately on APRV. He also gets patients from other units and from other hospitals that have severe ARDS, and he uses APRV on these patients also. Again, much different settings, different T lows, but really any patient from at high risk to severe ARDS, it can be utilized.
Thank you, Professor Nieman. And I think we'll just add another one or two questions. This is from Hara Al-Nasari. How can we manage APRV during hemodynamic instability? And should we continue to monitor driving pressures and aim to lower it to less than 15 in the TCAF method?
Surely driving pressure is critical, regardless of the ventilatory mode. But if you think about with standard of care mechanical ventilation, with the lower pressures and volumes and the differences in inspiratory and expiratory times, the lung does not recruit very rapidly. And therefore, the only option you have to reduce driving pressure is to decrease your volumes and your pressures. With the TCAV method, it is a rapid recruiter, rapid meaning hours or days, not minutes or seconds. But as you recruit the lung, the compliance goes up, and therefore your driving pressure goes down, not because you change parameters on the ventilator, but you change the physiology of the lung. So that's the one key thing to think about. There's two ways to change driving pressure. You can change settings on the ventilator, or you can physically change the pathophysiology of the lung by essentially putting an internal cast on it and casting it open, keeping the compliance high, and that will decrease your driving pressure.
Do we have time for one question? This is kind of more a question from one of that's in the physiology. It does make sense, but why we didn't prove any benefit for mortality in human studies?
It's surely that in the meta-analysis that I did mention to you, they do show decreased mortality, but these are very small studies. There just hasn't been a large randomized controlled study testing APRV specifically with the TCAV method versus the standard of care. This is being done currently in England. The PI is Dr. Luigi Campriata. I'm honored to be one of the consultants on that study, and they're comparing precisely the TCAV method to set APRV versus standard of care in 40 hospitals in the United Kingdom. Unfortunately, they just started recruiting patients, so hopefully in 4 or 5 years we will have data either showing one way or another whether the TCAV method is effective at reducing mortality.
Okay.
Right. Well, thank you so much, Professor Nieman. We have many more questions unanswered, but we'll try our best to write it on the chat and see if we can answer it. And again, you guys will receive an email with the recorded lecture, and hopefully we can also include some of the answers for the questions that were not answered. In the interest of time, we're short of time, but thank you so much, Professor Nieman. Dr. Mina, thank you so much. And do you have anything to say, Dr. Mina? Last words?
No, actually, it's a great talk. It gave us a little insight about other modalities that can help in treatment in this difficult patient. Thank you very much for the great lectures.
Okay, thank you all.
Thank you, everyone. Have a great day.